Hello, everyone. My name is Dr. Tina Yang, and I am the host of the Women's Health and Fertility Podcast. Today, we are honored to be joined by Dr. Stephanie Davis, a board-certified OBGYN and leading voice in female sexual health and menopause. Dr. Davis serves as program advisor of sexual and hormonal health at the Hoag Hospital Women's Health Institute, where she is dedicated to advancing evidence-based, multidisciplinary care for women across every stage of life. She is also a certified menopause practitioner and an active committee member of the International Society for the Study of Women's Sexual Health. Dr. Davis brings deep expertise and a passion for improving quality of life through personalized integrative care. She is also a Menopause Society certified practitioner and a fellow of the American College of Obstetrics and Gynecologists, with additional affiliations including the American Association of Gynecologic Laparoscopists, the North American Menopause Society, and the American Medical Association. Dr. Davis completed her undergraduate studies at Columbia University and earned her medical degree from the University of California in San Diego. She went on to complete her residency at LAC USC Medical Center, where she further developed her commitment to comprehensive women's health care. Known for her compassionate, patient-centered approach, Dr. Davis focuses on optimizing sexual function, hormonal balance, and overall well-being through individualized care. She currently practices in Tustin and Irvine, California, and she is a team member of the Orange Coast Women's Medical Group. We are so excited to dive into today's conversation on sexual health, menopause, women's health, and empowering women with the knowledge and care they deserve. Please join me in welcoming Dr. Stephanie Davis. Welcome, Dr. Davis, to the Women's Health and Fertility Podcast. I am beyond thrilled to have you on today for this interview. I was just looking through your bio the other week, and you have done such incredible and exciting things in the space of women's health. And I'm especially interested in the topic around sexual and hormonal health, which I know that you have sort of really diversified into. And I know that there's such a huge demand in that area. Seeing my fertility patients kind of go through, the process of having maybe one, two, or three kids, and then kind of going into that space of perimenopause is something that's really common in my practice. But I think hormonal health starts even earlier, and even in our teenage years too. And so what I've noticed in a lot of my patients and our mutual patients is that sometimes there are some hormonal imbalances that always existed, but perhaps they were masked by birth control, or maybe a patient might even have been dismissed and just told this is normal, and this is just what you have to go through, kind of suck it up type of thing. But I would love to hear more about your perspective on this and,
Mhm.
kind of what led you to this path of interest in sexual and hormonal health.
Mhm. Yeah, well, thank you, Tina. It's such an honor to be here, and I've loved the shared patience that we've had, the practice, the work that you're doing, and just really the integration for our patients that has been so meaningful and impactful for them, for us involved. And I think you are, totally right when you're talking about hormonal health and thinking about the sexual aspect piece does start from adolescence and beyond. It extends throughout women's fertility journeys through their reproductive years and well beyond it. And much of it starts from truly the education and empowerment that's happening before women are entering this journey, and really the gaps of knowledge that women are
Mhm.
having. There's a complete lack of education for
100%. Yes.
across the board, right?
Yes.
Right. Truly for our patients, for providers. This has been an ongoing issue. And, this whole topic that women are starting to talk about this when we talk about balancing, unbalanced, ultimately we are talking about a woman's hormonal access from the brain signaling down to the rest of the body and how all of that communication pathways integrate. And you're right that women are being dismissed. And ultimately, I do think that there, are very many well-meaning providers, people in the community and our patients are trying to seek that information, but they're not knowing where to look because their providers are not being trained with, even most medical students could not document what a menstrual cycle, what changes are happening with women's hormones during a typical menstrual cycle. And then you start getting all of these other pathways, inflammation pathways. You get these, what people describe as estrogen dominance, which is likely a lower progesterone state.
Mm,
And these changes that are happening as stress, as illnesses, as other hormonal or chemical pathways, metabolic pathways happening in the body are going awry. And so there is this piece of connective tissue in the body, of cardiovascular health, of nervous system regulation, right? That all of this is coming together, and that's very complex, very complicated
mm,
for
mm.
even the person with the most amount of training. And so we're kind of getting back to a ground level and really starting to, for women and adolescents, thinking about what does my menstrual cycle look like, tracking the cycle as a vital sign. And
Mm.
of course, this does mean usually for women off of birth control. And I think ultimately birth control, some of the medical management gets judged in certain aspects. There is benefit to what these medicines are doing for a lot of women, but there's also masking some of those symptoms of what does the cycle look like off of these medications. And that's has to be in line also with what are the goals of why women are even taking some of these
Sure.
medicines. Some of the time it's for contraception, and
Mm.
the risk of unintended pregnancy outweighs the benefits of these medicines. Sometimes it's for menstrual regulation, and it is helping the periods to be lighter and less painful. But to get to the root cause, which I think is really the integrative approach, the whole person approach, the finding the root cause of what is starting that inflammatory pathway. And for the most part, it is multifactorial. And so it is almost a detective hunt of really keeping an
Yes.
open mind and talking. It's multidisciplinary, it's multifactorial. We're putting all the pieces together and addressing, from a nutrition standpoint, from a metabolic standpoint, and then the hormones are one aspect of it. And it's one piece of the overall puzzle, and that's where it's putting understanding that lab testing for hormones is one moment in time. Right now, we have more of the urine testing that you can test throughout the cycle. We don't have
Mhm.
that available yet for blood testing, of being able to track those changes throughout, which ultimately is making women feel more confused and not have those pieces. And then you're getting from the Eastern medicine approach to the Western medicine approach and everything that falls in between. And people are hearing a lot of different
Sure.
perspectives, right? And so it's, I think really keeping an open mind when we have these discussions is helping to move that needle forward, of that hormonal piece of things.
Right, right. Well, I love your perspective on all of this. And as an OBGYN, I'm sure you see women of all ages. And so you're able to identify these gaps. And,
Mhm.
one thing that I see a lot in my practice, especially because majority of my patients are fertility
Mhm.
patients, or they're starting off as fertility patients, I should say.
Mhm.
I see a pattern of long-term birth control use for various
Mhm.
reasons,
Mhm.
but
Mhm.
usually even starting at the age of 15 and then
Mhm.
just being on it for a straight 15 to 20
Mhm.
years,
Mhm.
which unfortunately I believe flatlines their hormones. And
Mhm.
then when they're ready to start trying to have a
Mhm.
family, it's sort of like the HPO axis is not quite,
Mhm.
in sync, or it takes some time.
Mhm.
And then I see a lot of my patients getting a little bit frustrated and impatient, so they just jump forward to IVF.
Mhm.
And so
Mhm.
that's a common phenomenon that happens. And I totally get it. Everybody wants to have a baby
Mhm.
yesterday. I
Mhm.
understand that. And, sometimes these natural medicine modalities or integrative techniques like functional medicine and TCM or
Mhm.
traditional Chinese medicine take some time. And so
Mhm.
you have to kind of have a little bit of patience to allow your body to recalibrate and sort of rebalance out and get, the HPO access and the nervous system and everything back
Mhm.
into balance and homeostasis. And so I guess one of my questions for you is how would you, or what would you recommend for patients that are sort of in this situation? What would you say is one of the best things to do if you've been on
Mhm,
long-term birth control, so you don't really know what your
mhm,
organic vital sign of,
mhm,
of a cycle or a period is like?
mhm, mhm.
What would your recommendation be for
Yeah,
those
so I
folks?
think and this just it brings up how, women's reproductive health goes through very many stages.
Mm,
And in an era, and the Western medical system is really not designed for that preventive, proactive approach. And I do hope and see that the trend is moving that way as it should, of really getting ahead of it. So maybe, you're not ready to start thinking about childbearing right now if you're an adolescent, but then it becomes, let me start to think about this in different phases. And if we're not immediately trying to get pregnant, and I don't even have a partner,
hmm.
or I'm willing to consider other means of contraception
Sure.
as well, then maybe trialing off that patient on a long term hormonal oral birth control method, if there's ability to see, trialing off and seeing what the periods are like on their own. And
Hmm.
if they're, it's really about the education, right? It's addressing this. Do we want to address this from a holistic perspective and getting to the root cause and understanding, when you really start to peel back the layers, it takes time, and we may need to start things from a ground level and think about, what is the day-to-day life and those stressors that are putting on the body? What's the
Hmm.
exercise? How are you getting
Right.
movement in your body, right? How is your mindset about this? I really think that there's not enough to be said about our how our brain is connected to all of our other body functions, our metabolic functions. That mindset going in is, really, what is the end goal? And setting up now, it's like you're putting an investment into yourself for the
Yes.
future. Right. So
Right.
that's the part, like it feels like, yes, you want to get pregnant yesterday, but you're making this investment not only for right now that can improve, fertility wise for now, but you're also improving the metabolic stage of pregnancy, which is also going to set up the downstream effects of what that looks like after childbearing years. And when, the body goes through its
Hmm.
reverse, menses, when we start getting the
Sure.
perimenopausal fluctuations.
Yes.
So it's almost like, women are needing, like, to take a step back and be, I need a bird's eye view of what my hormonal health looks like throughout my lifespan. So that way, I really feel that education empowerment is the step to having women understand why they're doing those things, why they're making those changes, and that this is going to pay off forward. And to bring in that sexual health piece, because that is truly my biggest passion, is redefining sexual health as essential health. It is not just an indulgent, luxury that women have. This is about how your nervous system regulation is, how your body, your mind are connected, and how that surfaces. It's really a window into your overall health,
Hmm.
not just from happiness, quality of life, satisfaction perspective, but also, having that sense of self, sense of how your body works and functions at different stages in the cycle, different stages throughout your life, is incredibly empowering. And when you feel comfortable in your own skin, that's truly when women feel that agency. They feel more
Yes.
like themselves. And that's where I've
Mm.
seen, I'm sure you as well, like, once they come to who they are and making those positive changes, that's when we see actually women getting pregnant, after
Right.
years of not being able to. So it's an investment.
I love that. That is such a great way of putting it. And I think that there's, as women, we're always so hard on ourselves. And I think we just need to give ourselves some grace and patience, just like
Mhm,
we would a loved one. I
mhm,
think that we owe that to ourselves just as much. And, being able to give your body the grace to heal, to balance out, and
mhm,
have the nervous system reset. I think that
mhm,
that's perfect. And that's really great advice for women. And if women are, struggling with getting like, I think one of the things I've noticed, another area of struggle is getting like the right testing done
mhm,
for
mhm,
them, getting the right diagnostic tools that can
mhm,
help understand their bodies a little bit better. And
Mhm.
would you be able to speak a little bit about that, Dr. Davis, and
Yeah,
kind of how
definitely.
to advocate for yourself, I guess?
Exactly. I think this
Hmm.
is about an advocating and really, the advocacy sometimes is also an understanding that, most providers, if they're not willing to do this, it's I truly don't believe that they are trying to harm or intentionally dismiss patients.
Hmm.
It's really just about what the training was, because the hormonal axis is constantly fluctuating. So you're
Sure.
getting one moment in time when you're doing blood testing,
Right.
and especially if there's a condition where maybe aren't ovulating regularly, your periods are irregular, or if there's some
Hmm.
kind of birth control, there are limitations of what and when you can test. But, I do feel that there are a number, if you know where you are in your cycle, having regular cycles, testing around day 2 or 3, that's a
Hmm.
common ovarian reserve testing. Important to know
Sure.
it's not telling you about fertility in this moment, but kind of what the response to stimulation would be, ruling out some of the factors of why your body may not be ovulating regularly. I also find a day 19 or 20, especially progesterone level, to be helpful for confirming ovulation. We
Hmm.
can check in our cervical mucus, the consistency being that egg white kind of consistency, which is generally telling around the time that in your cycle where you are most fertile. Progesterone can confirm that kind of ovulation. But I think there's a number of testing that we can do also, and this again is more from an integrative lens, but of understanding, some of the vital cofactors in our metabolism, like vitamin D and our
Hmm.
iron stores, the
Yes.
ferritin, and there's a number of like even without lab testing, of really looking at like our diet and the movement again cannot be understated of what are we putting into our body on a day-to-day basis and how are we showing up for ourselves. That goes beyond, like, the lab testing is one aspect of that, the lifestyle is one aspect of that, and then you're also bringing in potentially some imaging. Imaging is getting more and more advanced as we
Hmm.
go along, and there's really this interesting piece of the inflammatory onset of many of these conditions that we commonly see and treat in gynecology, like endometriosis and
Hmm.
adenomyosis and PCOS, which is polycystic ovarian syndrome. And now we're starting to hear and talk a lot more about pelvic congestion and
Right.
MCAS, mast cell
Hmm.
activation, and
Hmm.
POTS. And it's a really interesting dialogue from multidisciplinary measures where you have different specialties that are actually seeing a lot of these conditions siloed, and then you're seeing from your aspect many of these patients who are even seeing all these different specialists that you are actually probably hearing from them more than individual providers are seeing.
Right.
But
Right.
it's when we have an open mind and we're listening to patients and we're actually seeing that our training, what we know at this moment, is still evolving and changing. We're understanding more and more, and that journey is really, it's because it's complex, but that's what makes it interesting and exciting. And there's some things that just on paper or in your lab testing, I think this is an important point to note, is that the diagnostic testing can come up quote unquote normal, right?
Hmm.
But that doesn't mean that the symptoms are not related to those fluctuations, or
Absolutely.
that moment in time. So I
Yeah.
think we also have to know what the limitations of what we are getting, but it's how we're putting that information all together, how you're feeling, and really keeping track of, like, during the cycle, how women are feeling at those different phases, because that also is bringing a whole layer of information gathering, and is really helping us to find what the correct course of action might be.
Hmm. Yes, thank you so much for taking such an integrative approach. Like, I am so happy to hear all these things. You are a practitioner of my own heart, just all the things you're talking about, looking at diet and
It goes right
lifestyle,
back the other way.
exercise, movement, and really like your mental, emotional state of mind. I mean, I think
Mhm.
like where you are at in terms of like your soul self, because
Mhm.
we can get pretty beat down when we're not feeling well, when we're not sleeping well, and all, the different health challenges that we can face because of some of these hormonal shifts and imbalances.
Hmm.
And like you were saying, there's such a variety of things that can come up, inflammatory conditions and nervous
Hmm.
system issues. And so I'm so excited that so much of that is being revealed and looked at now.
Hmm. Hmm.
And women are actually taking the time to advocate for themselves. So I think we're kind of shifting now.
Hmm.
And as far as for this kind of transition phase, so once women are done having their kids, it's there's never a dull moment in our life. We always have something exciting going on, whether
Hmm.
it's
Hmm.
we are trying to get pregnant or we're going through pregnancy and then postpartum and
Hmm.
recovering as, moms with young children. And then, once we're done having kids, we then go into this phase of perimenopause, which is my phase. And boy, let
Hmm.
me tell you, that has been one of the most challenging phases. And I joke around with patients that, it's almost symptoms are kind of similar like postpartum, where you're not
Hmm. Hmm.
sleeping,
Hmm.
you feel really tired, you have memory issues, but you don't have this beautiful baby,
Hmm.
so you're
Hmm.
kind of missing that element of this gift of life. And so you're just kind of left to your own devices, just feeling not great and
Hmm.
wondering like, what else can I do for myself, and then this is another opportunity for us to kind of be hard on ourselves again.
Hmm.
Like,
Hmm.
why am I feeling so tired? Or why
Hmm.
can't I remember this? I just,
Hmm.
and really having to write every single thing down. And I think this is sort of in Chinese medicine, we say it's like the second spring for
Hmm.
women. And I think we
Hmm.
really need to kind of embrace that phase of life and
Hmm.
again, give us ourselves grace and love. But
Hmm.
how would you say, or what kind of advice do you have for women that are going through that transition? And
I mean, this is my day to day. I love this question because women are truly incredible. And both of us have seen that, day in, day out. And on the whole, women are really high achieving, set a goal in
hmm
mind, go after it. What's next? What else can I, do to make this stable, move on to the next project. They're goal setters. They are, trying to, check the box off the to-do list. And those responsibilities and tasks go up with time.
Sure.
And you're right, each step from the moment that women, if they're choosing to go through the fertility journey, that becomes, goal number one. Then they get pregnant. Now it's how to stay pregnant, how to have a healthy
Mhm.
delivery. Then they're, put into the transition of postpartum, which is a menopausal state. Everything suppressed of very
Mhm.
similar symptoms of
Right.
menopausal symptoms in that time, on top of, taking care of a newborn and all, the routines that are constantly changing. Your body's changing. This is this word that has recently come up of matrescence, is such a beautiful word that is signifying the emotional, the physical, the neurological changes and transitions that actually I found out just recently that word is not actually in the dictionary, even though it
Should
is
be.
such should be, because
Mhm.
it is just the changes that women that the transitions that women go through in their life is not appreciated enough for how many challenges that brings. And we're in a generational gap where now, not only has the day-to-day, work of living gone up, but now it's the aging parents, it's the,
Yes.
raising
Right.
teenagers,
hmm
the, raising the household, the cost of living, the there's so many, it doesn't get easier. And I think that ultimately, this is kind of where you go back to that adolescence of, of building that armor as you go forward with that
hmm
education empowerment of knowing what's coming. And I do think that in the era that we are of talking so much about these topics, which is so important, and I hope that we never stop, because that is where the advocacy is coming from, is that we were never taught any of this. And we were not, some of the shock factor is actually coming because, our moms, our aunts, our
Yes.
grandmas didn't talk about this. And so the assumption as women is that I should be able to do this. I
Right.
should,
Right.
be able to handle it. And when women are not feeling that they are able to adequately handle it, they are feeling like failures. They are being hard on themselves.
Right.
And really, this is a failure of the system, of society, of the focus that we've had on women. And so, having that investment into self feels like a luxury, even though it is clearly not. I mean, this is arguably for you, it's the whole oxygen mask on
Yes.
yourself before
Yes.
others,
Right.
right? And we're
Yes.
not good at doing that. Many women are, we take care of everybody around us. We are last on the table. That self-care piece is becoming, such a oh, it's like as if you have time for self-care. I'd love to meditate, but who has time for that? And it's really, we are going through major transitions. And if we knew that from the beginning and we knew what symptoms to expect, to think about, to talk about, to bring up, to find providers who are going to be part of that conversation, that
Mhm.
partnership, this is a journey. And, just as it takes a village to raise children, it also takes a village to get through this perimenopause to menopause transition because we
Amen, Dr. Davis.
we were
Yes.
not meant to do this alone,
Right. Right.
and there's such a beautiful community that's coming together now of
Mm.
women helping each other, what's working for them. And I do think that we're moving in a positive trajectory here of even if you yourself may not be feeling these, you're at least now going to be around women who, if they are feeling symptoms or this conversation is happening, you're going to be talking about it, more aware of it.
Mhm.
And that is going to at least help to address, even before you get to that stage, what it won't feel as such a shock to the system if
Yes.
we know that, okay, this is supposed to be hard and we can actually address this together.
Yeah. And I love that analogy of educational armor. Like that
Mhm.
is such a great way of putting it. Because we do need the armor. We do need the protection and the awareness. And it's being proactive and being prepared, and it's unfortunate, I think, that the past generations maybe didn't feel comfortable talking about it,
Mhm.
and or talking about it with their daughters,
Mhm.
or their nieces, that's but I think that we're in this new era where everybody's like, yes, let's talk about everything.
Mhm. Mhm.
So
And I'm hoping, I'm glad the pendulum is swinging to talking about the challenges that are happening. I think so much about that mindset and that, nervous system regulation. So I don't want women to stay in that place and not feel like they can find solutions to come out of it, because that's also part of this whole discussion is that there are many treatment modalities. There's many multidisciplinary resources at women's fingertips, and not everybody has the access to attend to all of these things. But from there's many things that we could be doing day to day, of doing really like a self-reflection of where we are in our life, in our career, in our family dynamic, in ourself, and this is a great time if you have parents to be talking with, of really trying to understand what they went through and what some of the limitations, because I do think that women do feel empowered, that even if they themselves never had these conversations with women in their lives, it's interesting now as these conversations happening that it's almost like a healing process to find out, oh, actually my mom, my aunt, my grandmother did
mhm,
go through a lot of this, and these are the reasons why I didn't hear about it. Maybe they
sure.
did try to bring it up and they were dismissed. Maybe, they had a hysterectomy, they had a uterus removed when they
Mhm,
were
mhm.
30 or 40. And so they
Right,
actually don't
right,
know when these changes happen. So no one
right.
guided them along this pathway. And so, I do think that we're kind of at the stage right now where we're acknowledging the gap that has happened for women for centuries. Women are outliving their ovarian function. And
Mhm.
now we're starting to really understand the physiology and the metabolic changes leading up to that, that will, our daughters, our, the younger generation of women are going to be so much more empowered, and in this age of information being more accessible, that really setting up for success going forward. So it's the trajectory is definitely improving.
Yes, I am so excited about that. So for those women that are kind of going through that transition of perimenopause and menopause, what is what is your experience in practice with hormone replacement therapy, bioidentical
Mhm.
hormones
Mhm.
versus
Mhm.
traditional hormone therapy? This is
Mhm.
like the question that comes up a lot in my practice. So
All
I'm
the time, all
curious.
the time,
Yes.
every single day. Of
Yes.
course, of course. So, yes, I think this ultimately goes back to what is menopause and what is the time before it, right?
Hmm.
Menopause itself is clinically defined as 1 year without periods. So we don't need lab testing to tell us we're in menopause with the if you are having cycles, like if you are having monthly menstrual cycles, or even if things are getting irregular, spacing out, 1 year without periods is the clinical diagnosis. Now, of course, there's, times when women have had their uterus removed. They have maybe a hormonal IUD or some other hormonal contraceptive method that is stopping their periods from happening, or potentially they've had some other medication or health concern, including cancer treatment, a lot of chemotherapy or radiation that could um, make the ovaries not function appropriately. So many different definitions for menopause. Perimenopausal changes can happen 7 to 10 years before. So if the
Hmm.
average age in the US is 50, 51 for menopause, there's a range 45 to 55 in a spectrum. Then 7 to 10 years before is when perimenopausal changes happen, which is why so much of this conversation is, women in their mid 30s, early 40s could certainly
Sure.
be experiencing some of these symptoms. And on the whole, I think it's very much talked about the hot flashes and night sweats. That's actually one of the last changes that happens. And not every woman who's going through the perimenopause to menopause transition experiences those hot flashes, night sweats, and can experience it in different ways. Sometimes it's just flushing. Sometimes it's just a feeling of warmth. Sometimes,
Hmm.
it's not all, in severe cases, it is, waking up drenched, having to change clothing, imprint in the bed kind of situation. But, a lot of what I hear day to day, I'm sure you hear day to day as well, is the brain fog, is the
Hmm.
mood swings, the
Hmm.
irritability, the rage, the sudden weight gain, more, happening more in the abdomen, hard to
Hmm.
lose that weight, the palpitations, the dry, itchy ears,
Right.
um, you
Lower
know,
libido.
the low libido is one of
Hmm.
the hugest part, which,
Hmm.
I really think of, and I tell my patients this always of libido to me is not just a desire for sex. This is a desire for life, right? It to me, there's
Mm.
no differentiating
Good
between
point.
energy, motivation, just your sense of self, right? Every day women come into my office saying, I don't feel like myself anymore. I, I've lost myself, and the libido piece is what's so fascinating to me about that is that this didn't change overnight. This has been usually years in the making, and has been a change where they're now noticing it. And a lot of times, actually, a lot of the under recognized symptoms that women are going through, urinary frequency, urgency. It is common to wake up overnight to go pee. It is not normal. That is a sign that the body is changing, from a hormonal level, from a pelvic floor level, from the muscles, many different factors there. Incomplete emptying, vaginal dryness, discomfort, a feeling of burning, soreness that's happening. I am seeing this happen years before menopause happening.
Mm.
And, even in the menopause sexual health space, people are talking about the vaginal or genital symptoms happening after menopause. And every day I'm seeing this happen earlier and earlier. And when
Yes.
we treat locally with a lot of these hormones that's not systemically absorbed, and these are bioidentical options. Bioidentical just meaning the same hormones that your body produces on its own, which is estradiol, progesterone, testosterone. A lot of times the local hormonal treatments and that don't get absorbed into the bloodstream are so beneficial for the genital, pelvic floor, and vaginal vulvar
Mm.
function. So oftentimes that's a great place to start. And then, when we're
And
thinking
so
about the
these
body,
are, sorry, Dr.
go
Davis,
ahead.
just real
Yeah.
quick. So these are topical creams that you would apply.
Gels or creams.
Okay.
Yes.
Gotcha.
Yes. And these are, the recent AUA or American Urologic Association in the last year released national guidelines that's now endorsed by the Menopause Society, by the Sexual Health Society, that essentially there is no increased risk of cancers, clots, stroke, death, dementia. All the black box warnings that the FDA recently removed was because this was misinformation, false information
Hmm.
on vaginal hormone products that unfortunately limited many providers and patients alike from doing these life-saving treatments because the local hormonal treatments actually decrease the risk of UTIs by 50 to 60%. There's
Yes,
really
right.
no other medicine that does that.
Hmm.
Um,
It's
so
huge.
that part cannot be understated. And that's
Hmm.
a huge part of my sexual health practice is because sexual health, again, does not mean that you have to be sexually active or even partnered. This is about your overall health, your pelvic, your genital, your vulvar, vaginal, and urinary health.
Yeah, that makes a lot of sense. And so what about the other bioidentical
Hmm.
hormones? So the
Hmm.
patches and the creams and the
Yes.
oils.
So, and this is where women have options. And so much of this is no longer that this is a topic that you can just have casually, on your way out during your annual visit or on your way
Mm.
out from the office, because truly to be with a provider who knows all the options and is going to give that to you takes time to talk through all of that.
Yes.
Because there are different, what was studied, and it's impossible to talk about hormones without talking about the Women's Health Initiative that came in
Hmm.
the early 2000s, that for was a randomized controlled study. I know that the goals in mind were to evaluate cardiovascular function with hormone therapy. The issue for the generalization that has happened since is that there was an older population, average age of 63 in that study, and these were oral synthetic agents, meaning that not the bioidentical option, so not the typical estradiol, progesterone, testosterone. This was more of conjugated equine estrogen and the medroxyprogesterone, which is a progestogen. And so different than what's in birth control, but those options are also synthetics in many birth control options that use synthetics, so just kind of lab synthesize, mimic the effects of the hormones in the body, but act on the receptors differently.
Hmm.
So when we're thinking about bioidentical, it does not provide that kind of ovulation suppression. So it doesn't often provide the same bleeding control or contraceptive effects. But from this lower progesterone, like progesterone and testosterone are lowering with time in the perimenopausal fluctuations. Estradiol is what's going up and down and up and down. And, typically during a menstrual cycle, you get your estradiol going up and then coming down. When it starts to go down, progesterone goes down is when the period comes. But in perimenopause, you get this rise and the fall, and then it starts going up and down and up and down. And that's
Hmm.
when you think about that period of time, that's what's thought to be causing a lot of the bothersome symptoms because the brain, just like with any other fluctuations for sugar levels, the
Hmm.
glucose stabilization, same thing with your hormones. The hormones, they're in what we call this balancing is really just how, in what a typical ovulatory cycle will look like when it starts. What defines perimenopause is the erratic, unpredictable nature of this. And
Sure.
so bioidentical hormones are used to stabilize that kind of transition, stabilize the low lows from happening. And some perimenopausal women do benefit from a synthetic agent that suppresses that fluctuation from happening altogether. And maybe the bleeding is what's most uncomfortable or bothersome. So,
Hmm.
really, when we address from a hormonal standpoint, and addressing the perimenopause or menopausal symptoms, it's really what symptoms are most bothersome, what are we targeting, and knowing this is a journey as well. This is why with my patients it's a partnership because perimenopause is a moving target and it will stabilize once we get to menopause, when the ovaries are no longer stimulating and we're not fighting with that moving target anymore. So the treatments may be different throughout, but it's really addressing what are the symptoms that are coming up, what are we addressing, and how can we look at all of this from a more holistic lens of understanding again how our body systems and our nervous system and our cardiovascular and metabolic health, how all of that is integrating to find
Mhm.
the appropriate individualized treatment approach.
Right, right. That makes a lot of sense. And yes, it literally is a hormonal roller coaster when you're going through perimenopause for sure. So it sounds to me like most of the time your recommendation for women going through perimenopause is the use of bioidentical hormones. And at certain times, these synthetic hormones might be necessary for certain
Mhm,
patients. Is
mhm.
that correct?
Yes, I mean it's really what I do think that most women do respond better to the bioidentical hormones.
Hmm.
Not always, but many do, and in a stepwise manner. I think this is really, sometimes women are starting everything all at the same time, whether it be supplements, other lifestyle modalities, or medication management. And, I think this is really why it's important to work with a trained um, provider who has
Hmm.
expertise in these areas, because it's really about, understanding what physiologically is happening. How can we then add in and address as we go? And not to forget, a huge part of my sexual health practice is actually the testosterone piece,
Yes.
and not forgetting that testosterone is a
Right.
vital female hormone as much as it
Hmm.
is male,
Right,
and
right.
and this is where the lab testing, because there are no female formulations of testosterone, that's really how I got into doing lab testing in general for women, and have
Hmm.
found it very not only validating for women for what they're going through, because when you get that moment in time, and I typically will get labs around day 19 or 20, and the
Hmm.
perimenopausal time, I can actually see when estradiol levels skyrocket and get much higher than the typical, or much lower than the typical, and they're not yet menopausal. And then we're
Hmm.
getting our baseline testosterone levels, and the units are different. So women actually have about 4 times the amount of testosterone in their body as estradiol at any given point. And it's just that the units are different. We've gendered hormones, many different reasons for that. It's now part of the conversations with the FDA to have a female dosed product available in the US, which currently we do not have. But it's
Hmm.
understanding, testosterone right now from ISHWISH, the International Society for the Study of Women's Sexual Health. I encourage everyone to, look into that. Well, many of us know about the Menopause Society, but sexual health providers are really integrating a lot of this midlife health as well, and understanding from a non-gendered approach, that these are just testosterone. While Ishwish will say, postmenopausal low libido is the main indication right now, because we talked about libido as being a mood, as being more than just a desire for sex, it's very clear that testosterone has benefits in the brain for, the focus, that mental alertness, that
Right,
energy.
right.
It's great for our bladder is extremely androgen
Hmm.
dependent. And there's so, it's not always about one or the other. Sometimes it's about all of these approaches, how they come together at different times, and seeing what the benefits are. Many of these are done currently from a transdermal position, estradiol and
Hmm.
testosterone absorbed through the skin, which means it doesn't increase the clotting factors because we're not metabolizing through the liver. And that's a really important point
What
to
are
know.
the options for testosterone? Because
Mhm.
I hear a lot more about estrogen,
Yes.
estradiol, um, hormone replacement, not as much
Mhm.
about, in sort of the natural medicine world, I feel like testosterone is usually given as a cream or as part of
Mhm.
the pellet.
Mhm.
Um,
Yes.
but I was just curious, what are all of the options for testosterone supplementation?
Yes. So currently with testosterone, the ways that are most appropriate to dose would be a transdermal application with a gel or a cream.
Hmm.
Very often that means actually microdosing the male product, so using 1/10 of the male dose. And there's many
Mm-hmm.
different products for that, which most commonly I would say is a testosterone gel is
Hmm.
used. Testem or androgel are commonly used, and we use 1/10 of the dose, which sometimes that actually means that women have to do a little bit more hands-on work to dose that appropriately. And this is where
Sure.
monitoring the levels becomes very important, just to make sure that we're not overdosing, because we want to limit side effects of when the levels are too high.
Hmm.
And
And what are
then
some of the side effects for
yes,
too
yes.
high
Well,
of testosterone?
so physiologic, this brings up an important point of testosterone lab ranges for women are far too low. It says a 2 to 45 is normal. Really, it's thought in menopause and sexual health world that about 15 to 70 is more
Mm,
of the total testosterone. But then we have to keep in mind the sex hormone binding globulin, which is a protein in our body that binds the bioavailable or free testosterone.
mhm,
So it's looking at all of those factors. It is looking at the compounded version, which is dosed for you. So that's another option that is a cream form that women can use. This is why pellets are really not endorsed by any major medical society, because what pellets are injectable, implantable
mhm.
um,
Right.
hormonal options that make the levels actually quite high. And that's where we see more of those hyperandrogen symptoms, such as acne, hair growth where you don't want it, hair loss where you do want it,
Yes.
voice changes, the clitoris can actually enlarge. And the reason that a lot of, providers that are hesitant about pellets is because you can't reverse it once it's in place. If there are any of those bothersome side effects, you have to wait until the body absorbs the rest of that medicine, which
Mm,
often
that's
is
right.
in the form of 3 to 4 months
Right.
typically. And so so it is not part of my practice to do pellet therapy, and I think that there are safer, more effective means to start. But everybody has to find their individualized approach that adds on and the synergistic effects. There's more and more data now about how estrogen and testosterone work together. And all
Mm,
three actually, estradiol, progesterone, testosterone, are sex hormones. And
right.
so this is, you can't differentiate sexual and hormonal health, which is why I bring it all together, because
Sure.
it's very often we're losing, again, women are outliving our ovarian supply, and
Mhm.
we're born with all the eggs that we're going to have in our lifetime. So ultimately, a lot of this education is just going back to biology, right? We're just understanding what's happening in our bodies during these life transitions, and how can we stabilize, how can we support these changes. And that doesn't mean that we have to over medicate, but it means that we are understanding what the downstream effects are now, and the beneficial, this window of opportunity of the brain, the cardiovascular prevention, the prevention of osteoporosis. So how all of these hormones are actually beneficial for our brain and heart and bone and joints, and
Mhm.
um how we function day to day.
Thank you for that thorough explanation. So, how often would you recommend a patient to get their labs done if they are on some type of hormone replacement?
So typically, it's not actually indicated to do hormonal testing for the vast majority of bioidentical hormone therapy, including, estradiol or progesterone. Now, I would never gatekeep women away from labs, and again, I find it to be a validating piece of the
Mhm.
overall puzzle. But currently, it's really more with testosterone use,
Sure.
that it is recommended to monitor typically at 6 weeks, at 3 months, at 6 months with liver function,
Mhm.
just to ensure in a physiologic range. But oftentimes, like, getting other labs can be helpful, especially if there's concerns about absorption. Like, let's say
Mhm.
you're on a higher dose patch or gel of the estradiol, and yet you're still having hot flashes, night
Right,
sweats,
right.
or still having symptoms.
Mm,
Potentially at that point, this is where we're all still learning here about why some women are better absorbers than others,
that's
why
right.
what are
Yeah.
all the factors involved there. So some women may actually do better on a pill version
Mhm.
of the
Mhm.
estradiol rather than a transdermal, and it still is very, very safe, especially when you're considering what the actual risk of birth control is for the clots, and pregnancy, which people, I think, really underestimate how risky pregnancy is a
Mhm.
lot of the time. Um, and our estrogen levels are in the 3000s in
Right,
pregnancy, and so
right.
we don't test those levels day to day. And
Hmm.
really in the hormonal world, it is treated much more based on symptoms rather than the lab testing, just because serum levels don't correlate with tissue effects. um, but I think it's always part of the conversation of what is the goal. And if some women do like to track and do like to just assess where they're at, and as long as we understand it's one piece of the overall puzzle,
Right.
I think it
That's
can be a
right.
useful part of the
Hmm.
conversation.
I find that patients like data and it
I
kind of
love data.
right? It helps them feel like, okay, I'm doing the right thing, I'm staying on track, and also kind of fosters accountability on compliance with certain protocols too. So,
Yes,
so
absolutely.
that's good to know that that's the approach that you take and other, hormone specialists take.
Mhm,
So, what about the role of DHEA? Because that's another
mhm,
area that I see a lot of women coming in with prescriptions of DHEA or
mhm,
taking oral DHEA, and of
mhm,
course, we use it a lot in fertility
mhm,
for equality. That's a common
mhm, mhm.
supplementation for that. I'm just curious in your practice if you're doing anything in the space with DHEA supplementation.
Most of my DHEA use is actually topically, so for
Mhm.
vaginal health. So
Okay, interesting.
DHEA, yes,
Yeah.
and it is really fantastic for that use. So DHEA is a precursor hormone
Mhm.
to, which means it comes earlier in the pathway that converts to become estradiol and testosterone. And so, I do find with hormonal therapy, getting to the end organ or the end hormone is often very beneficial. And so I've found that DHEA, which is actually not a prescription when the oral use of it,
Mhm.
that's just over the counter. And there's wide variety of dosages. And so there's less studied specifically about, the oral DHEA that's used, and I find it to be more beneficial in younger women. The effects of it rather than in the perimenopause, menopause.
I see.
Certainly in the
Mhm.
menopause population, I'm not using DHEA as much or don't see the benefit of it at that
Right,
point,
right.
because then you're relying on the body's ability to convert those.
Correct. Right.
But in the tissue, in the vaginal bladder tissue, the vagina and the bladder share a wall, which is I explain this to him because this is not, unfortunately, commonly taught. When you have your vulva, the opening to the vagina, the urethra where you pee from is right there. And that whole area right at the opening where many women feel that burning, that soreness, that
Hmm.
irritation that's happening. This is a very androgen dependent area, which means that DHEA, testosterone, and estradiol are all going to be really beneficial for the tissue integrity, for the ability to stretch, which is the elasticity, the
Hmm.
collagen that's there, making the area more acidic to fight off overgrowth of the bacteria that we all have in our genitals. And so, vaginal DHEA, right now, there's actually only one brand name product that's called Intra Rosa. Fantastic product. It's a nightly capsule that women insert vaginally. Insurance coverage can just be challenging with that.
Hmm.
Sometimes it's compounded into a cream as well. But yes, my experience with DHEA is much more in the use for topically, for vaginal health, and not
Okay.
so much for the oral.
That makes a lot of sense. Well, so tell me a little bit more about You've mentioned a couple times that integration or integrative care is
Mhm,
is, is so
mhm,
important in your practice. So
mhm,
I am interested to learn a little bit more about the type of integration
mhm,
that you practice and what are some of the other providers that you tend to work
mhm.
with in your practice to serve your patients.
Yes. Well, sexual and hormonal health is truly so biopsychosocial, which means there's this biologic piece we've talked about now quite a bit, and understanding the hormonal aspect of things, the medication, the just health wise, how things are being affected. Then the psychological piece really has to do a lot with that nervous system regulation, that stress, that the wear and tear of the body that's happening with time. And so most commonly in my practice, I utilize pelvic floor physical therapy
Hmm.
because it's such a crucial piece of sexual health and just of overall health. because the pelvic floor is really that sling of muscles that, from just the moment we walk, from crawling to walking to, potentially carrying children to, any surgeries that have happened in the abdomen or the pelvis,
Mhm.
and then moving forward into menopausal time and the wear and tear of the joints, our hip bones, our hip joints, leg bones, everything's relying on this pelvic floor that has served us so well. And in an era where we're all sitting, hunched over on screens too, we're putting pressure on our spines, and then ultimately everything's getting kind of congested in our pelvic region. So pelvic floor physical therapy really are addressing that muscle component, that connective tissue component, the scar tissue mobilization. They're usually doing a lot of internal, external work. They do a lot of work teaching about breathing. I think
Mhm.
historically women
Yes.
are just taught, just do your Kegels, but who's actually making
Right.
sure that Kegels are the right thing to do
Yes.
for, a lot of times we need to strengthen and relax and learn how to relax appropriately these small muscles that are in our pelvis for everything to work well. We often have, pain points in different parts of our pelvis for different reasons. And pelvic floor physical therapy can be a huge adjunct to that. As you know, because we have a lot of shared patients, of acupuncture is a big part of my integrative therapy, because I do believe that's really working on that nervous system
Mhm.
regulation. It's working with the blood flow and how the internal cells of our body are communicating to one another, and just really looking at this piece of where we are feeling different sensations in our body, and that from the mindset perspective. I do a lot of mental health therapy recommendations. I think that's so important to think about our thoughts, our actions, our
Right.
behaviors. And then you have the acupuncture piece, we have the pelvic floor physical
Right.
therapy piece.
I
That's
love
kind of
this.
my probably trifecta of
Okay.
putting it all together.
I love that, Dr. Davis. Your patients are so lucky to have you as their gynecologist
Oh.
and OB. I mean, I'm hearing all the things that all the aspects of your practice, and I'm just so impressed and excited to continue to send patients to you. I'm sorry if I don't know, at some point you may have to stop taking new patients, but you are always on the top of my list of referrals. And
Thank you. You as well.
oh, thank you so much. And I just really, this has been so educational and eye-opening, all of the things that you've shared and the perspective of both from a Western medical perspective, integrative medicine, and more holistic model. And I think that this is definitely the wave of the future. I mean, it's already happening now.
Hmm.
And patients come in so informed, whether
Hmm.
they're
Hmm.
just learning about things through social media or ChatGPT or
Hmm.
AI. I mean, there's just
Yeah.
so much data out there. And so I find that patients come in super knowledgeable, even about
Hmm. Hmm.
supplements and other modalities of treatment. And I think having somebody like yourself who is so passionate about
Hmm.
education, I
Hmm.
think that that is sort of that perfect provider model for patients like this that are
Hmm.
coming in with so much education to begin with.
Hmm.
So tell me a little bit about things that are coming up for you. How do people get a hold of you?
Hmm.
Tell me about your practice and if you have any upcoming talks or events that you'd like to share about.
Yes. So it's always, clinic is continuing to grow and expand, and working on more and more educational opportunities for patients and providers alike. But currently, I practice in Irvine and in Tustin. I'm part of a group called Orange Coast Women's Medical Group,
Hmm.
and we are affiliated with Hoag Hospital, both at Irvine and Newport. And part of an overarching midlife and multidisciplinary program that we are building at Hoag, addressing these areas. And I'm building and growing a sexual and hormonal health program here that has a lot of this integration happening with different providers from the holistic standpoint, from the pelvic floor physical therapy
Love that.
standpoint. We are having, community talks that we're doing from a Hoag perspective, a lot that's focused on the midlife health. There's a huge push right now for the maternal mental health
Hmm.
aspect. And so well, a lot of actually for other providers, other CME type of activities, which are continuing medical education activities, and then provider patient community talks that are going to be about education during these different phases and different topics. So that's on the docket for 2026. I'll be speaking on a panel upcoming on March 10th that is going to be introducing Maria Sophocles and her new book, The Bedroom Gap, that we are doing with Gigi Kroll's practice and Pause to Action, and having some other sexual health expertise as
Amazing.
well. So that should
Yes.
be a fun event.
And
But
that
yeah,
March
a
10th
lot to look
event, is
forward
that
to.
local here
It's local,
in
yes. It's
Orange
at
County?
the Port Theater in Corona Del Mar.
Okay, well, I'll definitely include the link. I'm hoping
Yeah.
it.
Yes, if
Well,
it
will it be a
comes in
recorded
time.
event just in case that this
I
is
am
after
not
the
sure,
event?
but there will be many events that we're going to be doing through
Okay,
Hogue
amazing.
that we will continue to share.
How do patients learn more about the educational opportunities through Hogue?
hmm
Is there like a website? And I'll make sure to share
Yeah,
all
so
that information.
Hogue is building their menopause website, and so
Hmm.
that is going to be expanding in the coming months. But right now, if you search for menopause at Hogue, you'll be able to come to the major program that's happening on the OCWMG website is where
Perfect.
I am located with my bio,
Hmm.
and patients can call our office to schedule an appointment as well. And then we have a whole conglomerate now of midlife menopause certified providers through Hogue, and also different specialties as well. And so we have a good referral network. So, if you need a cardiologist, if you need an endocrinologist,
Love
that
that.
also is attuned to these changes in a
Hmm.
woman's life. That's also part of this. It's really about how are we bringing the community together, and then the goal, of course, is to expand education beyond for those who may not be local, or expanding access across the board.
I love that, Dr. Davis. It sounds incredible, and I'll be sure to share all of this information. Well, again, I can't thank you enough for being on my podcast. I'm so grateful for this inspiring conversation, and I'm looking forward to continuing to work together in the space of women's health through all phases of life. Any last words of wisdom or advice you'd like to give to patients or to listeners?
Yeah, I mean, my ultimate goal is truly the empowerment piece, having women be connected to their bodies, to themselves, and really advocating, and being encouraged to do so. To finding a care team where women are feeling supported, where they're being helped, being guided, and understanding that you do not need to do this alone,
Hmm.
and that there are providers out there that want and are excited to go through this journey with you. Because again, it takes a village. We're just creating our
Yes,
village is expanding.
right,
Not just during the reproductive years, but really moving forward and beyond, and even before, getting
right.
everybody, the sisters, the daughters, the
That's
friends,
perfect.
everybody's coming together.
Hmm.
So
Well, your
it's
village
just a
doesn't go
community.
away. You just keep
Your
growing
village doesn't go.
it.
Exactly.
Right.
Yeah,
So,
and there's different people that come into your lives at
mhm.
different times, and I think this is really the journey, the transition of life, and we're coming to understand more about the gaps that have happened, but we're also moving forward to really seeing, how we can do this in an informed, productive way, and really women are finding themselves again. Like that's the best part of all of this. It's
Yes.
so incredibly
Yes.
rewarding, fulfilling. I'm sure both of us is that that's part of this work, is that it takes a village, it takes internal, reflection, and taking work on an individual level as well. But the beautiful part of this is that when that comes together, there is so much valuable change that happens for a lifetime that is, you really can't, that can't be unmatched. Like that is
Mhm.
truly incredible.
I agree. I think we all deserve to be the optimal versions of ourselves.
Absolutely.
Yeah. Well, thank you again, Dr. Davis, for your
Yes.
time. I really appreciate
Thank
it.
you. Thank you for all that you do for patients, for the community, and just the expanding education, and being able to highlight this field and this area. It's really important work you're doing.
Oh, it's always a pleasure, and I can't, I think we share a very similar passion in just supporting women through life. So, but yes, thank you. Thank you so much. All
Of
right, Dr.
course, of
Davis.
course. Thank you.